with COVID? Let me just quickly say I got that. And so if I very briefly, because we haven't got it all nailed down and written into beautiful slides, but give you a little bit of an overview, talk you through. So living with COVID for me broadly has two big planks. One is we have to transition our acute response arrangements, basically winding down. And what we need to be very clear about is what's our destination. And it's important to say that our destination is not just, oh, well, we're packing up and go back to where we were. There are some real ambitions and aspirations that there will be a bit of a new normal. And the particular relevant ones for COVID, I think, are there is some expectation in terms of a new, what I call almost like a civic etiquette about how we socialize when we have a respiratory illness. Because the idea is that living with COVID means treating COVID like any other respiratory infections. Now, as a country, as a society, to be honest, in comparison to others, we have had a relatively laissez-faire attitude. You know, if you have a cough and you're spluttering and you're streaming, you soldier into the workplace, and that has been seen as a positive attitude. I think the ambition now is to readjust that and have a different civic attitude, that if you have respiratory symptoms, that you self-isolate. So that's the first important destination, so not quite business as usual. And then the second one is, despite COVID's suffering and tragedy, we want to leave the legacy where there were good things about COVID. And obviously this board has very much demonstrated, COVID has really highlighted the inequalities in our society, so it also therefore galvanized partners to do more something about it. And that energy and focus we must keep. The other one is around IPC. So we've, I think, skilled up and enabled our care homes to an extent that was never the case, and we do not want to just pack up and leave it. We want to really make sure that we leave those skills behind. And then the way we've had dialogues with our community, I'm looking at our primary care colleagues as well, you know, you lot out there day in, day out, that has been completely novel. And I hope we can build on that rather than go back and close the door. So transition winding down to a new destination. The second part of living with COVID is we have to keep our surge preparedness, because God only knows where this virus is going. Viruses mutate. And though we can hope that we've seen the worst of it, we can't be sure. And for surge preparedness, it is very, very important that we work very closely with the UK Health Security Agency and particularly with the NHS, so that with the resources we have jointly, we keep and have capacity in a most effective way. So just a few more, a bit more sort of flesh on the bone. You will remember the cornerstones of our acute response. One was testing. So you will ask me, how we transition from testing. You will have heard the changes nationally. So symptomatic testing, so PCR testing and asymptomatic testing with LFTs will be wound down and not anymore freely available from 1st of April. So we have to work with the Department of Health and Social Care around more or less just the logistics of winding down. You know, the PCR testing sites need to be given back to their original purpose. And we have to bring our community with us. And so, for example, the asymptomatic testing in some settings, it will continue, like care homes, in the health service, in our SEND schools only until 1st of April. So we have to really prepare and support them. But that's a given that we cannot go a different way. And I think as well, we don't want to go a different way, but it will be quite a change. What follows if we don't test, we don't have data, and already the data set that you've got today is less reliable than they were before, because people are already voting with their feet and they do not test as much. So we will not have a surveillance to the extent that we shared. We are working very closely with UK Health Security Agency to say, well, how do we know? Driving blind is never a good idea. So nationally, they will continue with the infection survey, but that's about 150,000. It's a sample. So we then have to extrapolate what will that mean. The other important bit is all our eyes and ears on the ground. So if we find that there is illness, respiratory illness, be it in a care home, in a school, in a community, then we have to work closely with our outbreak, our health protection teams from AXA. And if there is a suspicion that there is an outbreak, then we can mobilize testing. It's very different, but that's the plan for going forward. If we think about contact tracing, remember, we had to build it up. It was really hard work. We had amazing people helping us, because we basically just set it up new. That has finished 24th of February. The national system finished, and if there is no national contact tracing, there is no local contact tracing. So that is quite abrupt. And just to let you know, we obviously very much work with our HR department, so that the people who worked in contact tracing have a fair exit. And we're thinking quite creatively. You will have heard, and we've discussed it here, that during the pandemic, there are a number of children, and Eleanor, you will know particularly, that are really missing now from the education system, really worrying. And so we're using some of our skilled contact tracers to help us find the missing children. So that is the type of thinking creatively, how we make best use of the skills that we've trained up. But there is no money for local authorities to do additional contact tracing. If we would have to search, we would have to set it up again and expect to be paid for it nationally. Very important IPC, so infection prevention and control, one of our real, I think, areas to be proud of. Fantastic teams and fantastic collaboration. We've had some prudent and frugal use of our, what is called the Contained Outbreak Management Fund, and we have the assurance that we're allowed to roll over a little bit of that fund. So we are not stopping abruptly 31st of March, we're tapering so that we can really prepare the care homes, leave skills behind over a longer period of time, up till the summer at least. And then finally, really, really important, vaccination, and we will come and discuss that in more detail, because the subgroup obviously played such an important role. That's not going to go away. That's one of our main ways to keep our population safe. And so there's lots of ongoing work. We are lucky that we got the vaccine champion funding, so that goes at least into the summer. And obviously, the main work is done by our NHS partners, and our role is supportive, linking up with the community, and we are completely committed. And we're completely committed to keep the focus on equity. So that hopefully gives you a little bit of a flair what it really means living with COVID, and how we're getting to that place. Lots of uncertainty. as the new sort of arrangements and roles and responsibilities are being worked through. I stop here, Chair.
Thank you, Dagmar. And I think, to your point, that while there is uncertainty, I think we can feel somewhat assured about the networks and the expertise and the relationships that have been developed in the borough over this period to support residents. But inevitably, there will still be levels of anxiety, particularly over this sort of quite quick switch, perhaps. I wondered whether there were any comments from the group on living with COVID, or any questions to Dagmar. Just have a look for hands, or feel free to shout out. I can't see any. Dagmar, I was going to ask a question actually about the end of lateral flow tests, or free lateral flow tests, and that was particularly in relation to care homes, and whether care homes would continue to be provided with free lateral flow tests, and the same for NHS staff.
Yeah. So if I come back, the details I haven't got all up my sleeve, and NHS colleagues might want to chip in for the NHS. For the care homes, we have assurance as high risk settings. Regular testing will continue, and they can order their supply as before. Details to be determined, but it is, for example, quite important, and it has caused quite a lot of ruffles and anxiety, that while we're moving towards not testing anymore, send schools, for example, at the moment still continue to test, but are expected to stop the regular testing with the 1st of April deadline. So there's a distinction between care homes and SEND schools.
Thank you, Dagmar. If I could actually really quickly follow up, just because we obviously do work with a number of partners, particularly voluntary and community sector organisations who provide care and support in the community. Do you know whether they would fall under that category, or it's sort of still to be determined, depending on? So
we're lobbying quite a bit. There's also a lot of discussion who's going to do stockpiling, because they're, in cupboards and on windowsills, loads of tests are still around. So how can we ensure that the use of those tests is most meaningful? And how are we ensuring that the most vulnerable settings have ongoing supply? So details of that are being worked through, and if you can lend your voice as well to some lobbying, that this is done in a collaborative way, absolutely considering the voluntary sector, that would be helpful.
Thank you, Dagmar. I can see hands from Vasa, Ellie, Una and Mark. If I go to Vasa first.
Thank you, Chair. And first of all, I think we must thank everybody in this group and all the other contacts of the people in this group who have really done a good job on this particular topic in the last 2 years. And happy I am that we have come to the end of that particular part of the journey. I'm sad because this has been a group of genuine friends who have worked together and achieved a lot. And I think we should celebrate, though we are saddened by the loss, we should not be ashamed to celebrate the good which has been achieved, not only in the short period, but the platform it has created for us to work together with all the other equally challenging issues which we have to now solve in the next few months and few years. And I like to go back to that particular word, social etiquette, or normalization of social behavior. We normalized in the last 2 years, and we must be careful that we don't normalize back to where we came from, because that will be unfair by those who are extremely vulnerable, and those who are extremely vulnerable require us in leadership not to be ashamed to talk about the needs of the vulnerable. And a person's vulnerability is only known to that person and to their carer. So I don't walk around with a badge on my forehead to say what is my personal vulnerability and what is the vulnerability of someone who is near and dear to me, whom I have a social responsibility, a civic responsibility to. And I think this is where some more or other, we have to now find all the energy and the effort, which is harder than what we've done in the last 2 years, because then that was the normal then. In the new normal, we have to courageously advocate for those who are increasingly vulnerable. Now, that doesn't include ill people. That also includes the bus driver who is currently well, but he has a bus full of 50 people in a closed environment. And we really need to develop that civic sense now. He is more vulnerable than I am in my office or in my room. The back door can be opened by me. I open the back door. I may put the heating up. Sorry, Dagmar. I may put the heating up a little bit, but I open the back door. The poor bus driver can't leave his doors open when he drives. And I think we just need to develop this way of thinking about all of us trying to think of walking in somebody else's shoes and knowing what their occupational vulnerability is, what is their social vulnerability. And as I said earlier, that responsibility falls on those in leadership, because if we don't remember that, then I'm sorry, we have failed.
Thank you, Vasa. Ellie and then Una.
Thank you, Chair, and thank you, Dagmar and everyone for the work. I just want to, well on, Dagmar's point, we've currently still got an absence from school issue going on, not just in Merton, but across the country. I suppose one of the things that I'm thinking about is to what extent that becomes almost permanent and built in, because as Dagmar said, if there is less presenteeism accepted, will schools not be doing their 100% certificate awards? And whilst there's questions about whether they were ever a good thing, it would be damaging if we end up with actually expectations of lower absences. So I think that's going to be one of the big challenges as we move towards the living with COVID and living with this. And I don't think we can answer that now, but it's something that I know my CSF colleagues are working really hard with schools on. I think will be a challenge over the coming years.
And shall I very quickly say, Ellie, absolutely, and we are feeding that back up the food chain, nationally. I'm working with the Association of Directors of Public Health. We've actually got quite a good relationship with the Secretary of State for Education. We had a meeting with him yesterday. And it's not only that the absence figures then will be different, and good figures look different. It's not 99.9% anymore. There is the other issue around equity, because if we're expecting sick kids to stay at home, somebody needs to look after them, and there is a differential in terms of control. And if you haven't got agency in your job, what are you doing? So there is a lot more to think through, and with the stopping of the self-isolation funds for those who need it, that is one of the crucial, in a way, holes in the fabric. If we want a different civic attitude and etiquette, then we have to have the robust underpinning. And so that is the message that has gone back up. You can't have it all. And we need to be very, very aware that we're not inadvertently creating more inequities. So very, very aware. And again, your lobbying up there is really appreciated, because this is all forming as we are all learning.
Thank you both. Una and then Mark.
Thank you. Yes, I mean, I think it is indeed, it has been a steep learning curve for us all. And I think certainly from my side, I lobbied before Christmas to keep the lateral flow tests going and to make sure that they were still free. And I'm continuing to lobby for that, because I think that's one big plank which should be kept, at least in part. And in my household, I have a carer amongst our body, and I think it's important to be able to know, albeit that this is just one, and I accept that too, that in living with COVID, we've also got to live with other illnesses. And of course, we're not testing for a number of other infectious and respiratory illnesses, but certainly at the moment, it's still high. I know 1st of April is a date, but to my mind, that's a fairly plucked out of the air date, because it doesn't seem to me to be close enough to the summer. But I don't know that, obviously you might comment otherwise, but it seems to me that better to have it a bit longer before we completely withdraw them, and to ensure that certainly some of the more vulnerable groups are covered with free ones, because it seems to me that going into care homes, or if you're in a family with carers and so on, people you know, if you've got used to testing, which I think, you know, I think most of us have got used to it, it just makes some sense. And you know, prevention's always been a strong plank, certainly of all of our work. And so if this is helping to prevent other infections, and particularly in more vulnerable groups, then it just makes sense. So I certainly support lobbying to continue for certain groups the lateral flows, and indeed any other planks of what we've all been doing. And I think I certainly welcome this group, and I commend all the past work that it's done. So thank everybody. And yeah, as I say, I think I've no doubt that there'll be other mutations or infections, and it's great that we've come together to try to help, and hopefully have achieved some legacy, albeit amongst some pretty awful stories as well. But I'd just like to thank everybody too for everything that they've tried to do. So thank you.
Thank you, Una. Mark, and then Mohan.
So I suppose I'm going to be a bit of a worry monger. So I suppose just on the back of Dagmar's comments, particularly about a new normal, isn't it? It's a new normal where actually COVID and post-COVID services are part and parcel of the new world. But remember that actually during COVID, we had additional resources that came through many different work streams to kind of enable us to respond. And actually we're coming out of that now. And so therefore it's really critical that we look at how we are absorbing the services, but that people are accessing the right care, the preventative care from the right place at the right time. Because, I've just been on call for a week. And hospital activity is, I've known in my very old life, I don't think I've ever seen it this busy. And it's not just about COVID, but COVID plays a part of it as well, because you've got to have different IPC regulations, you've got to be able to flip wards, etc. So I do think we're going into a kind of period where we're going to have to really look at services, and are we pitching them to the right people at the right place? And that's a collective we. I think it's from the voluntary sector right up to your kind of specialist tertiary centres as well. So it's just, we've got a lot of work to do, I think, to rebase the systems.
Thank you, Mark. Mohan?
Yeah, thank you all, and thank you, Dagmar, for the report. And I think we've been waiting a while to hear that report sort of down across the board. I think last time we met, there was sort of some going up, some going down. So a good time to transition, I feel, if there is a time to do it. I think it's symbolic as well for our community, with going into spring and summer, where we know that rates tend to be more open and outside. I think that bodes well. We can always bring it back if needed, and certainly that might be a strategy as we enter winter 2022, although we're still in 2020. Well, yeah, the last year one, but yeah, you know what I mean. So yeah, I just wanted to add that in. Thank you.
Thank you, Mohan. I can't see any other hands, but just to say thank you to Dagmar, but thank you to everyone on this group that I know has put a huge amount of hard work into everything to get us to a sense of sort of this new normal that both Dagmar and Mark mentioned, and looking at sort of how we adapt services. And I'm sure that this will be a conversation that is continued as part of the Health and Wellbeing Board as well. But just to sort of also echo my thanks to this group. So that takes us quite nicely into the next item, which is the future of the Health and Wellbeing Board community subgroup. And I know that the report was circulated with the agenda on how we sort of approach our new normal, but I will hand over to Dagmar to present the report.
Yeah, so thanks very much, Rebecca. And I don't think I need lots of time, because it follows really quite logically from what we've just discussed. So as we're in the transition to wind down our acute response, we are also reviewing what is the governance, and we want the governance arrangements to mirror that we are not in the acute emergency anymore. And so the proposal for this subgroup, therefore, is we presented some options, and we are proposing that the subgroup stands down as a regular group meeting, but keeps the commitment to form a task and finish group, stand up again if circumstances change and the need arises again. So that responds in a way to what I said to you with transition into living with COVID, but we keep some search capabilities if circumstances change. And just to make sure, we therefore propose the focus on equity from the subgroup was particularly pertinent. And the proposal is that the Health and Wellbeing Board will continue, particularly to keep an eye on what's happening to vaccine equity, because that was obviously one of our foci, but also thinking around long COVID, which we will cover a little bit later, and the particular importance of equity in creating equitable access to long COVID services, and also the access to therapeutics, again, equitable access to therapeutics as our sort of new and important measures to keep us safe. Just to reassure you, so that proposal is very much in line with what we are also doing with our Borrower Resilience Forum. That's the statutory forum where we bring wider partners like the police and our business sector, etc., together. And we had also formed a specific core group of the BRF for COVID that regularly met. And so we are having a last regular meeting and for the Borrower Resilience Forum to go back into normal business, but with the ability to stand up if required. So I'm also assuring you, and I think that is important, and the report describes it, that the legacy issues that we discussed, the heightened focus on equity and reducing inequalities is obviously picked up now in our ongoing strategies. So our local health and care plan is one where we bring the Health and Wellbeing Board partners together, our health and wellbeing strategy, and also the Merton plan to go forward as the London Borough of Merton, which is called Merton 2030. So there are other vehicles now to not lose in the sort of legacy aspects. So therefore that's a sort of rough canter through, and therefore I recommend to you to approve the option 3 as per report.
Thank you, Dagmar. Were there any comments on the report or the sort of other options, or the, I suppose, the approach that's being recommended? I'm going to take silence and no hands as consensus that, oh no, Una.
And just to say thank you for the report, and following on from what we were discussing, yes, I think it's very sensible what's been proposed and fully supportive of the option that allows us to reform should that be necessary. I'm sure we can all say that we very much hope that that wouldn't be necessary, but given how viruses can mutate, it makes huge sense to have it sort of on the standby. Don't quite know how that works and whether it needs to go. I suppose my other question is whether it has to go to Health and Wellbeing Board to be approved as an option, etc. But I would commend that action. Thank you.
Thank you, Una. Dagmar, did you want to come back on that? I think we
so just in terms of there is a formal process, I think, and Clarissa needs to chip in if I don't get it spot on. So if we as a subgroup agree, then we can recommend it to the Health and Wellbeing Board, and because we are accountable to the Health and Wellbeing Board, they I'm sure will approve, and that's the sort of process done. Clarissa, have I got that more or less correct?
Yes, absolutely. Yes, it's on the agenda for our next Health and Wellbeing Board.
Thank you both. And I imagine that as we move into sort of recovery and building resilience post-COVID, COVID will continue to be in some ways on the agenda of future health and wellbeing boards anyway. So it should hopefully allow some sort of seamless sort of signposting to setting this group. But I can't see any further hands, I don't think. So I will take that, that we have considered the options that were presented in the report, and that we are happy to press ahead with option 3, which will be taken to our next Health and Wellbeing Board, which is later this month. Great. Thank you. And then just moving on to item 6 then, which is an update on the vaccination programme, the equity update. And I'll just hand over to Julia and Mohammed to present this item.
Thank you very much. So we have some slides. I don't know if Clarissa could present those. Is that okay, Clarissa?
Yes, sure, Julia. I'm just trying to get them up now.
Okay, thank you. So what we were going to do was I was going to hand over to Mohammed, who was going to just talk through the current vaccination programme and some of the data. I think Katie Bulger unfortunately couldn't attend this meeting. So I think Mark should ask you to cover a couple of slides after Mohammed. And then I was just going to round up by talking about the Vaccination Champions programme and some of the kind of challenges going forward. So if that's okay, I will hand over to Mohammed.
Thank you, Julia. Next slide, please. Great. So our aim in Merton is to achieve equitable vaccine uptake for all the residents. And we see this through 4 key enablers. And that's number 1, reducing barriers to access, making vaccines accessible to all residents in Merton. So that's looking at vaccination sites, community pop-up sites, etc., and also pharmacy sites. The second is communication and engagement. So engaging with the underserved population, working with them and promoting vaccines. Partnership and governance, working in collaboration with other stakeholders and ensuring that we're working together on shared outcomes, and making best use of the data, information and insight. So that's evidence-based, looking at qualitative and quantitative data, and making sure that any action that we do is based on up-to-date and recent information. So just looking at the vaccine timeline and from where we started. So we started right at the beginning, phase 1, April 2021, where we wanted to vaccinate the most vulnerable. So we started with cohort 9, we worked our way down. We've moved on to phase 2, where we wanted to vaccinate everyone over the age of 18, and that was completed by 31st of July, or the majority of people were vaccinated then. And then we moved on to the phase 3 offer, which was started in September, with the aim of providing a majority of boosters to all over 18s by March 2022. We're now going into phase 4 of the programme, which is looking at second boosters for those that are most clinically vulnerable and 75 plus, as well as looking at providing vaccinations to the healthy 5 to 11-year-olds. After this phase, we're looking at the ongoing vaccinations in the community, long-term plan, and providing an infrastructure if there is a requirement for surge vaccination. Next slide, please. So the guidance is constantly changing and is constantly being updated. And this is sort of a snapshot of where we are at the moment in terms of the guidance. So if I start with the clinically vulnerable, which was recently introduced only about a month ago. So the 5 to 11-year-olds who are at high risk, they're currently eligible for their primary dose. So that includes the first and second dose. And the interval between that is 8 weeks. Currently, they're not eligible for a booster dose. We await advice from JCVI on that. Young people who are at risk, 12 to 17, they're eligible for their first, second, and a booster dose. And the interval between that is 8 weeks. If they've contracted COVID in that time, the interval is 4 weeks. Anyone that's aged 5 and over, living with someone who's immunosuppressed, is also eligible for a COVID vaccine at this moment in time. They can have their first and second, but still, if you are between 5 and 11, you won't be getting a booster. But if you're over the age of 12, then you do qualify. Any patients that are immunosuppressed themselves, they will be receiving a letter from NHS asking them to come in for a third dose, which is slightly different from the booster. And then 3 months from the third dose, they'll be getting a booster, and that gives them the best protection possible. And then if we move on to the healthy children and young people, so the 12 to 17 age group, they're eligible for their first, second, and third. However, the interval is slightly different. It's not 8 weeks, it's 12 weeks between their doses, or if they've contracted COVID, 12 weeks from that date, whichever is later. However, the 12 to 15-year-olds at the moment are not eligible for their booster. We're still waiting guidance from the JCVI, but up until about 2 months ago, 16 and 17-year-olds were called for their booster, and that's 12 weeks that's 12 weeks from their second dose. And it remains the same for adults. Anyone over the age of 18 can get their first, second, third booster at 8 weeks, and if they've contracted COVID, it's 4 weeks since then. Just to give you an update on recent changes, so there's no longer a requirement for healthcare workers and adult social care workers to be fully vaccinated by the 1st of April 2020 deadline. So there's no need for that at the moment. And then new cohorts are going to be introduced in April 22. So we're looking at the healthy 5 to 11-year-olds. They'll be getting their first and second doses. However, the interval between it won't be 8 weeks, it'll be 12 weeks. And then the second booster doses for those that are clinically vulnerable, 75 plus, and looking at all residents in care homes as well. Next slide, please. Thank you. So overall, Merton has done a fantastic job in vaccinations. We've provided over 400,000 vaccinations across Merton. 72% of residents over the age of 2 have received at least 1 dose. 67% have received at least 2 doses, and 49.4% of over 12s have received a booster dose. The booster dose will be slightly low for the 12 plus because, as we know, the 12 to 15 are not eligible yet for a booster vaccine unless they fall into a high-risk category. There's still about 62,000 residents that remain unvaccinated. So if we look at the graph on the right, so this is looking at vaccine uptake amongst Merton residents in terms of age groups, and we can still see that in the lower age groups, so between the 12 to 15, there's still 52% unvaccinated. This is in comparison to the older age groups over 50. So there's still some work to be done in the 12 to 30 age bracket. Next slide, please. So this is looking at vaccine uptake for all people over the age of 12 by MSOA. So that's looking at areas, the geographical areas in Merton. So moving from left to right, the first map shows the first vaccine uptake by first dose, and then second dose and third doses. But the general information we can get from this is that there is higher vaccine uptake west of Merton than east of Merton, and that goes across for all 3 vaccines, first, second, and third. But that increases with the booster vaccine, as we can see on the last, on the furthest to the right map where there is significantly lower booster uptake in the East. If I can go to the next slide, please. Thank you. So this is the vaccine uptake by South West London. So this is just looking at where we are in comparison to other boroughs in South West London. If we just focus on the third doses for the moment, we are the bar that's completely shaded in black, the solid black bar, and the uptake is about 48.9%. So these are the residents that have had 3 doses. We're 5th in South West London, and we're continuing to work with our networks to increase that uptake and vaccine partners to do that. If we're looking at first dose only, we're seeing that it's 5.1%. So those are patients that have had only 1 dose and are yet to have second doses. So that's a good thing, because we want first doses to be low. We want third doses to be high, second doses to be high. So that could indicate people that have just received first doses and are waiting for a second dose. But we can still see, looking furthest to the right of the graph, that there is about 28.1% unvaccinated in Merton, in comparison to our neighbouring boroughs. If we can go to the next slide, please. So this is looking at vaccine uptake by ethnicity in Merton, and we can see that there is a disparity between different ethnic groups. There is a higher unvaccinated proportion of people amongst ethnic minorities compared to white Irish and white British residents, especially with the Black and African Caribbean communities. There is a very low uptake in vaccine with this community. A recent GLA poll, February 2020, looking at vaccine uptake amongst different ethnic groups, found that white Londoners are significantly more likely to have received the booster, 83%, than other ethnic groups. All other ethnic groups are significantly less likely to be fully vaccinated, including the booster. So Black Londoners 54%, other and mixed ethnicities in London 61%, and Asian Londoners at 69%. So it's quite similar to what we're seeing in Merton as well. Next slide, please. So I'll hand over here.
Thank you very much, Mohammed. Mark, did you want to come in on these, or do you want us to? Great.
No, I can just quickly touch upon them. I mean, I think some of the figures that Mohammed has illustrated, when you first look at them, you say, "Oh Lord, why is Merton 5th in that graph?" And then when you do look at like the deprivation across southwest London, actually you always think Croydon and then East Merton, and it is very much linked to our deprived areas and also our ethnicity within those deprived areas. So that context, we need to remember why, you know, the people that are not coming forward for the vaccination, and hence we need to start thinking about that evergreen offer and actually taking the vaccination out to them. So we've done a lot of engagement and communication work through community organisations, including the BAME Voice, Polish Family Association. We've gone through schools. We do a weekly COVID newsletter. We're working with community young inspectors, and also the COVID champions that I think, Julia, you might be mentioning later on, which are going to be really key, because I think from the outreach work that we've done and the engagement that we've done, one of the key messages from communities is that often there's a mistrust around NHS services, or that banner of NHS does not attract people through the door. So actually really working with our community champions and our community organisations to lead the fight, so to speak, and actually the health services are behind the scenes, and it's a kind of, you know, it's a secondary reason for the conversation, is going to be really key going forward, because we are seeing some people come forward for their first dose, but one conversation is not going to achieve it. It needs to be an ongoing dialogue. We've got a community outreach grant scheme to work through community organisations, and we've done work, as mentioned, with the schools. We're also working with the St Heliers antenatal team to really promote COVID vaccinations in pregnant women. Accessibility. We've had 40 pop-up vaccination clinics. We continue to do them. If anyone has any good ideas about where a pop-up clinic could be, Mohammed will be on it like a shot. So we do want to keep getting people's ideas, because we do know that all the community, all the great pop-up work we've done, but we've still got the disparity there. We've still got the inequality. So we've still got to go back and offer the evergreen offer. Next slide, please. Just some of the sites that we have done, ranging from New Horizon, Power Centre Church, the Nelson, Holiday Inn in Collier's Wood, particularly around asylum seekers. So again, it's just about really thinking where we can take the vaccination programme to in different settings that aren't necessarily considered health settings. And again, we want people to get really involved in helping us identify sites and settings. What's the challenges? I think Mohammed's already kind of touched upon this. Younger age group, pregnant woman, our BAME and our people from ethnic background groups, absolutely. Our asylum seekers and homeless, again, a challenge, but also making sure that we're identifying the clinically vulnerable and prioritising the immunisations for them, like housebound and care home patients, and making sure that that's a regular kind of touch point. Some of the learning, we're going to continue with the vaccines, but we do need to also just think about, are they in the right places? We need to start to, we've been using community pharmacists, but I think we can be using pharmacists for much more. And we could be delivering much more through the community vaccination sites as well, and bringing new vaccination sites in pharmacies going forward. And then we've mentioned general inspectors, COVID champions, etc. So Julia will touch upon that. Next slide, please. I think I'm handing to you, Julia, am I?
Yeah. That's it. Yeah, thanks very much, Mark. So I just wanted to spend a few minutes talking about a new programme, which is very much building on the COVID champion model that we've been, has been taking place throughout the pandemic, where we've had weekly and now every other weekly sessions with community champions who are out there kind of talking to their neighbours, friends, colleagues, organisations about issues about COVID. We've now been given a grant of just under $500,000 to really focus on trying to reach the communities in the borough, to talk about vaccination, to try and build that trust, to get those who haven't been vaccinated to take that first step, and perhaps those who think 1 or 2 doses is enough to become fully vaccinated. So we are going to use that funding. We've been asked to basically deliver between March and July. We're actually going to stretch it out, hopefully further than that. And there are a number of components. So the first is really about developing a network of networks. And so Merton Connected are going to help us with this, which is really providing quality training for volunteer champions to feel confident to have conversations around vaccination and share those messages with their network settings organisations. I'm going to take a vaccination plus approach. So all the evidence says actually it's much better to talk more broadly about people's health and well-being rather than just talk about vaccinations. So it's very much about being able to and feeling confident to have those wider conversations and signpost people appropriately. We're going to work with those communities where you've heard from Mohammed and Mark, we know we have lower levels of uptake, and try and build that confidence and trust. We're also going to have some on-street engagement, and this again is about delivering a brief intervention, having these focused where there are pop-ups and other clinics, because we know that will help encourage people to take up the offer at those pop-ups. And we're also offering some clinical support. So actually volunteers might not, need to know the limits of their confidence and what they feel confident talking about and what they don't. And so to have some clinical backup to really provide some support is another element of it. We are aiming to get this up and running in this month. So we will hopefully very soon be sending out kind of publicity about this. Next slide, please. I suppose just wanted to touch on, before we kind of open up for discussion, really, what are the new challenges that we're facing? And, Mark, you might want to come in on some of this. So one of the challenges is, the downward trajectory in vaccination for people who were enthusiastic and have had theirs. The challenge really of reaching those who've made a conscious decision not to get vaccinated. As Mark said, it's not just a one-off conversation, it's an ongoing conversation about the issues and the challenges facing those groups and communities. It's also really thinking about where we best give access to vaccination, bearing in mind some of our vaccination clinics will be scaling down. And also, new campaigns, as Mohammed said, the pro-vaccination program is changing all the time. So making sure we're being responsive to that. And then also being mindful that we need contingency plans in case of any surge of new variants, as Dagmar set out in her introduction, that actually we need to be planning for different scenarios. So I think those are some of the challenges going forward. Mark, I don't know if there's anything you want to add.
No, I mean, I think you've covered most of it. I think there is something about also when we talk about vaccinations and sites, that, you can have a pop-up site, but actually it might be about a pop-up site consistently being in the same site over a period of time, which might, people need to get to know something, trust something, hear about it from perhaps peers. So I do think we need to think about, not just single pop-ups, but actually, regular pop-ups that become part of the community fabric, so to speak.
Thank you, thanks. And just final slide, Clarissa. Just really in line with the decision that those groups made, we would like to make sure that the focus on vaccine equity becomes kind of overseen by the Health and Wellbeing Board. So that's just a final comment. But if I hand back over to you, Chair, and open up for discussion.
Thank you, Julie. And I know that you ended that presentation on challenges. But while we're sort of winding down the subgroup, it's really encouraging to see how much work is going on in the background around vaccination, and particularly, I think, speaking to our priority in Merton around inequities and bridging the gap from east to west. There's a huge level of focus and commitment in that. So that's hugely encouraging. And just, I suppose, to open out to the group, if there were any comments, possibly on, I feel like it's been the continual challenge in terms of how do we reach those who possibly don't want to be reached, or to increase sort of access availability to the vaccine. I don't know whether there are any comments or questions perhaps on the presentation in the group. I feel like it was incredibly comprehensive, that no one has any comments or questions. It was an incredibly comprehensive presentation, I must say. Mohan.
No, it was completely comprehensible. So yes, absolutely. I wanted to, it was interesting, Mohammed, when you had the stats about the vaccine 1, vaccine 2, and even though there was a reduction in East Merton, it wasn't as dark as it wasn't as light, I should say, as the booster. It really was the booster where it became a much greener and yellower sort of pattern. And so I wonder whether that was the tricky bit, is getting boosters into our already vaccinated population, and they felt that wasn't what they need, that they weren't ready to go for that third step. And I suppose if there's any data around those who have been hospitalised on double vaccines versus the triple vaccines might help sort of guide that further with that group. And certainly in East Merton, in deprived areas, we've been struggling for years about how to support their health and wellbeing, and support not just vaccine uptake, but also diabetes, asthma, COPD, the whole lot. And so, yes, I agree with Mark, it's a continued engagement on a continued process. And I think linking in with the community and the leaders, and as you've done with the pop-ups, has really forged a way to kind of develop further links and further pop-ups, not just vaccine, but other things as well. So was there a question in there? I don't know, but that was just my initial thoughts around that. But I suppose 2 versus 3, what has that done in real terms, and is there going to be a 4th? But sorry, too many questions. But yeah, they're my comments. Thanks.
Thank you, Mohan. Did anyone want to come back on those points, or should I take additional sort of questions? Oh, Mark, did you want to come in? Yeah.
I suppose probably just around the data, because that's quite it's something that we need to be very careful about, really, because people are admitted to hospital and then have a COVID diagnosis. And it might not be their initial presentation at hospital, but it might well be a complication, or it might well be, it adds to the statistic. And what we have seen is we've seen the kind of the profile of acute admissions change. We certainly do know that on our ICU wards, that those that tend to be having the worst reaction are those that haven't been vaccinated and haven't had the booster. But it's just a word of caution around data, because we did, hopefully Dagmar will back me up on this, you need to be really careful about the interpretation of data, because we can often come up with the wrong answer.
If I was just going to come in as well about some of the kind of data, which is more about the insights. So the ONS publish sort of regular insights, and their latest information is that of Londoners who've had 2 vaccinations, 1 in 10 are unlikely to have a booster, and 42% think they don't really offer protection. So I think there's a real issue around our communication and messaging, and I think the making sure our our champions are really kind of well informed to be able to have confident conversations around the evidence will be really important.
Shall I also maybe chip in, because just a slightly different angle. We mustn't forget that we had really high infection rates. So people who might have had 1 and 2 and then got an infection quite reasonably say, well, that was my booster. And I do not think that our communication has quite picked up. But what is in the back of our mind, and for me that is really, really important, it's not about us hounding down people. It is for us to listening to really, people aren't stupid. They have their own approaches and theory. And actually, they're not even far off, because if you have a mix of vaccination and infection, your antibody levels are tip-top. So behind the scene, as I said to you, is the ONS does infection surveys, but the ONS also looks at antibody levels in the population, and particularly amongst young people, we have got very high antibody levels. What the point I wanted to make is not that we now can all go home because everything is dandy, but that we are continuously having a dialogue rather than preach, and really understand what are some of the underlying reasons people give. And because of the different intervals as well, particularly amongst young people, remember, if you had an infection, you need to leave 12 weeks before you can be vaccinated. So it's not that long ago that Omicron hit. It's actually still pretty much out there. So there's also still a lag. So all of that we need to take into consideration as we are continuing to build vaccination into our sort of protective measures. And I particularly am very, very keen to have the vaccination plus approach. It's a lot of effort in the vaccination, and people make an effort and staff make an effort. So the more we can hook in to that interaction, the better. And again, listening to what makes sense to people as well, what they want to be hooked in when they make the encounter. Thank you.
Thank you, Dagmar. Bassa?
Thank you. Yeah, and I think we sometimes forget that this whole booster of the booster program was only in December 2021. It's just 2 months ago. And there are people out there who had that booster or didn't have the booster because they fell ill before the booster could get to them. And one thing I'm confident, Dagmar, that we're not going away. In every practice, there is a clinician beavering away. When I go into a room in my practice, there's one doctor. And when I go to a room late in the evening, I can assure you she'll be staring at a dashboard, which only she opens on a virtually daily basis. That's her mission, and she will do her best to bring them home because she has got the right attitude and she got the right approach, and she's the right person. So in the practice, we know who is the right voice, the tone, the approach to talk to people. As you said, Dagmar, listen, not to talk at, not just to listen and find out. I think I think practices are best placed because we know our patients. We know at times we know what language, I mean language meaning in English, how to talk it, or what non-English language we have to sometimes get through to talk to people so that people feel that it's genuine listening exercise in this. And there's work to be done because we know our data at practice level. We look at this dashboard and we know who is due the third. And don't forget, Dagmar, there are people who need the extra, the fourth one, you could say, because they are severely immunocompromised people. And those people, you must remember now that when things open out, people will start visiting those severely vulnerable people due to their medication and illness and organ transplant, etc., etc. So it goes on, it doesn't stop, and it will not stop because we know we owe them a duty of care, far greater care than to others who are well and able. And I'm confident that with talking and explaining, and the data is out there, Dagmar, if you look at the data from what we hear from the ITU doctors, that if you had two, it wasn't enough. In December 2021, having two wasn't enough, but having the third one was certainly keeping you well away from the ITU job. So I think that's the message at local level. We talk on a one-to-one basis to tell people. And Mohan, don't worry. I don't think you asked us a question. You made some observation and you had some comments, but within your observation and comments, there were a lot of important information for us to gather.
Thank you, Bassa. Were there any final comments or reflections? I can't see any. It's just for me to say thank you to Julia, Mohammed, and to Mark for that presentation, which was incredibly comprehensive. And I know we won't be meeting again as a subgroup, but I'm sure that an update will come to the Health and Wellbeing Board or another outlet, and we'll look forward to hearing progress on the latest programme. So I think that brings us to our final item of the night, which is on post-COVID syndrome or long COVID, and we'll hear about the latest developments and emerging evidence. So I will hand over to Barry, Mike, Amanda and Monica, I think.
Thanks, Rebecca. Clarissa, we've just got some slides. I wonder if you could bring those up for us, please. Thank you. So I just want to start by introducing myself. My name's Amanda. I am a GP trainee that's currently working in the London Borough of Merton. Just want to introduce my colleagues too that will be going through this long COVID item with me. So we have Monica Koo, who is a public health intelligence specialist from London Borough of Merton, Mike Proctor, the Director of Transformation from the South West London CCG, and Barry Causer, Public Health Lead for COVID Resilience. So the purpose of this item is to provide an update on the estimates of the burden of long COVID, looking at the different modelling methodologies, and update the board on the emerging evidence and the known unknowns, taking into consideration the uncertainty of long COVID, set out the role for primary care of managing long COVID, and discussion and proposed next steps for moving forward. Next slide, please. So this slide's just a recap on the clinical definitions of long COVID. So we have acute COVID-19, which this defines signs and symptoms of COVID-19 up to 4 weeks following infection. Ongoing symptomatic COVID-19, this defines signs and symptoms from 4 to 12 weeks. And then post-COVID syndrome. So this definition is for signs and symptoms that develop during or after an infection that's consistent with COVID-19, continue for longer than 12 weeks and cannot be explained by any alternate diagnosis. So there's no standardized definition of long COVID, but long COVID is used as a bit of an umbrella term and encompasses both ongoing symptomatic COVID-19 and post-COVID syndrome. And just to note that long COVID can affect anyone with who has been infected by COVID-19 virus. Next slide, please, and we'll be handing to Monica.
Great, thanks, Amanda, and evening all. So I'm going to be covering some of the evidence on long COVID, particularly when it comes to prevalence. So first of all, estimating the burden of long COVID, there are several models that have been developed, but these are primarily to help people understand the demand for long COVID services. And so they estimate the number of new long COVID cases that are thought to come about on a weekly basis. Because the models are based on the best available information, they do not include the impact of vaccine rollout as of yet, changes to COVID treatment protocols, and some of the latest changes, including sort of the Omicron and Delta differences. Because evidence on recovery is also still being collected, this means there aren't any prevalence models yet, which means that if you go to the next slide, please. Thank you. Which means that the best estimate of prevalence of long COVID, so how many people have long COVID at any point in time, is available based on the ONS, ongoing ONS survey of long COVID in the UK. So first we wanted to start off with a picture in the UK. Around 1.14 million people are estimated to have long COVID in England. And as you can see from the graph on the left, that estimate has been increasing since August last year. If you look at the graph on the right, where you can see the estimated number of people who are experiencing long COVID by age group along the x-axis, and then separated out into how much their activity is disrupted or limited, you can see that first of all, the bars, the total length of bars for the 35 to 49-year-olds and the 50 to 69-year-olds is biggest. So a greater number of those age groups have reported long COVID, and also a greater number of those age groups also have reported that long COVID limited their daily actions, activities in some way. Next slide, please. So using these prevalence estimates that are UK-wide to try and give a very rough estimate of the potential number of people in Merton who have long COVID, we've estimated that there are approximately 4,200 residents who are currently living with long COVID. Again, thinking about the patterns that are seen nationally, we have estimated that women and individuals aged 35 to 69 are more likely to be experiencing long COVID. Next slide, please. Finally, thinking about the emerging evidence, I've already talked about some of the unknowns, but as we get further evidence on the impact of vaccination, so there's some early evidence indicating that vaccinated individuals are less likely to develop symptoms of long COVID after infection, so that's something to watch. And also thinking about the impact on cardiovascular disease. So your likelihood of experiencing cardiovascular disease has been shown to be slightly higher among individuals following COVID-19 infection. This is based on quite early evidence coming from the US, so I think we need to wait for some more representative data that is on a more sort of ethnically diverse population relevant to Merton. But that's, again, something to keep an eye out on. Other things that we don't fully understand, again, the most recent Omicron wave that we have seen, there is data emerging on that, but not sufficient enough to really bring to this group at the moment. And NHS England, London are undertaking a number of rapid reviews on particular focal points, so the impact on employment, thinking about the long COVID among the CYP, so children and young people, and finally thinking about the overlap in symptoms of post-COVID syndrome and menopause as well. So again, we'll be keeping an eye on those areas. I believe I'm handing over to Mike now. Oh, Mike, I think you're muted, Mike.
And here I was talking to myself. Okay, I'll start again. So we can see the pathway here. Hold on, I'll just make sure that I can see it myself. This shows the service we have, which is basically an assessment service, and this has been running now for about 9 months. And this is staffed by therapists principally. Since this service was established, we've been getting a fairly steady level of referrals. And the interesting thing, if we look at the estimated prevalence data that we've just been considering, the numbers that we're getting aren't anything like that level. The referrals into this service are around about 15 to 20 per week. And if you think about how many that is over the sort of 40 weeks or so that we've been running this service, then there's clearly some unmet demand out there. But this is the pathway that it is. So when GPs refer into the service, there has already been some diagnostic tests done. They will be looked at by our assessment service. And then there are a number of potential treatment modalities that can then follow, depending on exactly what sort of symptoms they are. As you'll be aware, post-COVID is a strange collection of symptoms, some of them not terribly precise. And sometimes, as we've already mentioned, diagnosis is more a diagnosis of exclusion, in that there is no other explanation for this, rather than because you can necessarily clearly demonstrate that it's post-COVID. So some of the symptoms, just like brain fog, fatigue, anxiety, fairly general. So depending on those, there are a range of services to which patients can be signposted. And we follow the patients up after 4 weeks, after 1 to 2 weeks, to make sure that they're getting the services that they need. If we go on to the next slide. So this sets out the role of primary care. And because this is basically where patients will initially present, in most cases, there is the National Enhanced Service, which supports practices in delivering their requirements. But the third bullet point there repeats what I've already sort of highlighted, that the numbers of referrals we're getting through are a long way short of the estimated prevalence. Now, those estimates we know are probably imprecise anyway. They're just estimated figures. However, the variance between them and the numbers we're actually seeing coming through the service is very small compared to what you would think. So the service, that figure of 15 to 20 patients per week in terms of referrals, I should add, is Merton and Wandsworth, because this particular service covers both boroughs. One issue that we have had is that the funding that was provided nationally to staff this service has really come through in rather frustratingly small dribs and drabs. where money has been promised but has been slow to arrive. And the issue we have there is that obviously we have to employ staff with the appropriate qualifications and experience to manage some of these cases, because they are difficult cases to manage because of the fact that there is this variety of slightly imprecise symptoms, and it takes some experience and a senior therapist to do the assessments. So we haven't been able to make a point because these are skilled staff who have options as to where they work, and if you can't offer them any security, it is very difficult to recruit them. We've recently had some greater certainty over the funding, both for the financial year that's just ending and also for next year. So that's now resolved, and we're able to get the service back up to what we would like it to be in terms of offering treatment and rehabilitation, as well as the assessment and signposting, which is that first bit of the service. If we go to the next slide, I can't remember what's next. Oh, that's just the discussion, I think. Okay. So who am I handing on to now?
It's me, Mike. Thank you.
Okay.
So thank you, colleagues. So we've set out for the committee this evening the estimates, the uncertainty, and some of the challenges around long COVID. And I think similar to vaccinations, we aren't quite done with long COVID. And so our proposed next steps are to continue to focus on long COVID whilst we transition to living safely and fairly with COVID-19. So making sure that the plans that we put in place include long COVID. We've touched on already from Julia and Dagmar about vaccination plus approach. So making sure that those vaccination champions are also able to raise awareness of long COVID and therapeutics, etc. Next steps are to participate in a peer review of our services and a maturity matrix for case finding. And what essentially they are, that's two tools to understand how we're doing, any opportunities to improve our services, and also to learn from others. And as Mike set out, there's a clear difference between the estimates and the number of people going to services. So again, the case finding or the reach into communities is something that we can do well on. And again, I think it's fair we should acknowledge the good work that we've done in Merton at the same time. So when we go into those peer reviews and talking about case finding, we have good plans in Merton, and I think we'll be able to share a lot of those with our colleagues across London. An important next step for us is to conduct a health equity audit, and that's going to be really important for us to kind of examine those health needs, understand who's less likely to access our services. So we've understood the gap, and we can put plans in place to be able to support them to access services or self-care management tools, depending what their clinical needs are. And similar to the discussion we've had probably 3 or 4 times this evening, but utilise the existing governance and structures that we have in place in Merton, because we do have the Health and Wellbeing Board, but we've also got a really functional, and it's well chaired by Mike, Merton and Wandsworth, post-COVID syndrome steering group, which has actions. It meets every other week, and we've got a meeting tomorrow. And then clearly we've also got the Merton Health and Care Together network as well. So colleagues, that's our proposed next steps for discussion, and I'll hand back over to Councillor Lanning.
Thank you, Barry, and to Mike, Amanda and Monica for that presentation. I think it was a nice shift from the vaccination update to that one, just highlighting the importance of vaccination there as well. And I would just open out to comments from colleagues or any questions on the programme that was set out. Vasa, then Dagmar, then Mohan.
Thank you, Chair. Yes, and thank you for a brilliant summary of all what has gone on, because when this began, a lot had to be done in a very short time to get the long COVID service going. And I wouldn't say that, though the gap looks very wide, in actual fact, it's not that wide, because there are patients who have come to see us in practice where the predominant long COVID symptom was cardiovascular, or the predominant long COVID symptom was respiratory, or rheumatological or dermatological. And these patients were never sent to the long COVID clinic because they had a single system disease which was predominating their symptom burden, and rightfully so. They were sent to the dermatologist or the rheumatologist or the chest physician or the cardiologist, and therefore they wouldn't really go to this clinic to make up the numbers of long COVID, but they do make the totality of the consequence of long COVID. So yes, there's a gap, but it's not as wide as we might fear it is today. But that doesn't mean we are complacent. We still go on searching for those who have the symptom, the burdens of the symptoms, haven't really sought help yet. And that is where the champions come in to go out there and to legitimize and make people feel that they are totally justified in seeking help, because those who have survived the disease now need to overcome the consequence of the disease. And yes, it's quite burdensome. Even if you say they are non-specific fatigue and brain fog and insomnia, they're quite debilitating from a person's quality of life and functioning point of view. And that's why, as Barry said, this goes on. This doesn't come to an end.
Thank you, Vasa. Dagmar?
Yeah, hi. So thanks very much for pulling it together. I think recognizing that it really is an emerging field is crucial, because we have to keep our mind very open. We simply don't know what Omicron has up its sleeve. There's really positive stuff, the vaccination stuff. You know, if you're vaccinated and get infected, you're very likely to get less COVID, long COVID. That's brilliant. And that's more just, okay, vaccination prevents you from getting COVID. No, even if you get it, you then don't get long COVID. There's even more exciting research out there that says maybe vaccination can work for some people as a treatment of long COVID. Now, if you think that through, that is really exciting in terms of research as well. It has some potential problems as well, because for some, it might make it worse. But the reason I'm saying it is that it is an open field that requires an open mind rather than knee-jerk reactions, and that's what we have to keep. In terms of our focus and our sort of raison d'etre as a group to think about equity, though, it is very, very important that the numbers and the gap, I wouldn't particularly hanker about the absolute numbers, because as Vasa said, there's something not quite right. But where I'm more wary is the distribution. We do know which communities had the brunt of the waves. And we are then needing to compare whether proportionately those communities get the access to services. And that's where some alarm bells are ringing, because I can't see that. And if you then listen, and we have our community champions, we've got our vaccine champions, because the symptoms are so vague, there are cultural ways as well to talk and make sense of these. And I feel we are much too unsophisticated at the moment, because we have a sort of standard model about long COVID, but different cultures, different communities make very different sense of some of those symptoms. And so what we've again pushed up the food chain in terms of more research and more learning required is much more cultural variation. And typically, you know, research is not necessarily done on diverse communities. It's often very stereotypically a subset, and we need to be aware that we might fall prey to that. What's also very important, that not all you know, suffering translates into clinical pictures. You know, if people just feel tired and without energy, etc., it can still be suffering, but they don't link it to a clinical need, and we don't want to necessarily medicalize. But we have got social prescribing, and we've got other support, and I think really counting in the voluntary sector with some of their lower levels of support, because a lot of what people say is, oh God, I find it so hard to go to work. So therefore, supporting people to keep their jobs even for a little bit longer, it would be one thing. The other thing people say, I find it so knackering to care. You know, we've got so many informal carers. If we can tune in where some of the lower level support can also chip in to tide people over, because hopefully there is recovery at the end of the tunnel. It's a more holistic picture. And I think the health equity audit that Amanda is going to help us to do is trying to explore and bring a little bit of a wider perspective into our picture. Thank you.
Thank you, Dagmar. Mohan and then Mark.
Thank you for putting this together. And I'm going to mention a sort of combination of what Vasu and Dagmar mentioned, certainly about the clinical picture of long COVID or post-COVID can be dealt with in lots of different ways without needing a referral. And also the social prescribing network, and it'd be quite nice to sort of include that as part of the plan. And certainly in primary care, when we have patients who have non-medical causes of long COVID or post-COVID, we've been referring to social prescribers. There's actually a tab on Elemental which has got post-COVID, so they've been picking up referrals through that route. So useful to include that. And also in the trust, so the post-COVID clinic, we've also had a dotted line to all the link workers across Wandsworth and Merton, so that actually once they've been medically optimised, they can refer directly in to see the link workers. So actually we've gotten referring in from primary care and actually from the long COVID clinics back out into the community centre. So it's really integrated, really sort of aligned nicely. And while this works for post-COVID, I think this sets the bar for actually other long-term conditions. But while we're talking about post-COVID, it might be helpful just to put that in as a dotted line, because Mark, we did spend some time with the link workers going through that process. And I think it's picked up a few referrals, not a huge amount, but that opportunity is there. Thanks.
Thank you, Mohan. Mark?
And I suppose it's just, we've had a number of conversations tonight about being led by communities and listening to communities. And I suppose is the audit where we'll capture the patient voice. Where does the patient, their experience, etc., get captured in this? And I suppose that's, Barry, Mike, etc. It's a kind of, where do we capture the patient voice to help us design the service and implement the service going forward? And particularly when we're talking about the inequalities piece.
So I think, Mark, it's in a number of different places that we capture that voice. Firstly, it's through that health equity audit. It's through our community champions network. It's through our vaccination champions network. But Merton and Wandsworth, actually no, all the health watchers across southwest London published a report on Friday afternoon about their findings from talking to residents all across southwest London on long COVID services. So again, it's benefiting from those networks that we've got, the things that are already happening and the structures. So we've got plenty of places to get that voice. And I think if we're able to direct them into, and we can screen it and work it well through that post-COVID steering group chaired by Mike, and then onto the Health and Wellbeing Board, we've probably got the right governance structures to listen to those voices.
And I suppose it's just, there's that voice of caution, I think, probably, that we're talking about perhaps the communities that do not come forward and access services, aren't we? And so therefore don't necessarily fit into a community organisation. So it's just something about, we need to remember that some of the communities are not, they're not in our kind of conversations at the moment, and we need to, we need to take that step out, don't we?
We do. And again, just to kind of address that point, I mean, through the vaccination champions work, we're working really closely with the voluntary sector. Over half of that, the funding that we've got is going directly into the voluntary sector to work with us going forward to understand how we can support and understand those residents. So again, it's working with those range of networks that we've set up throughout the last, 2 years. That's been quite a challenge.
Fantastic. Thanks.
Thanks, Mark. Thank you, Barry. Were there any final comments or questions, or did any colleagues who presented want to make any final remarks? No. So thank you very much for your presentation. And that was our last item, and I appreciate this is also our last meeting. So I just wanted to say thank you to everyone, and also possibly end on a somewhat cheesy note, but I do feel incredibly proud to have been part of this group and feel very fortunate to have such fantastic colleagues across Merton and across the system who are so committed and so aligned for our residents here in Merton. So just to say thank you, and hope to see you all again soon. Good night. Bye.
Thank you.
Bye.
Good night. Thank
Bye.
you.
Night. Bye.
And can I commend you, Rebecca, as well?
Bye. Thank you.
Absolutely.
Thank you.
Thank you all.
Enjoyed working with you. Thank you very much, everybody.
Bye.
Hi, Bola.
Yes.
Brilliant. Thanks ever so much.